Hello, everyone. Thanks for joining us tonight. It's 7 o'clock on the dot. We'll give all participants a few minutes to log in. We're seeing a bunch of participants joining in. Well, first of all, my name is Louis-Philippe Bouchie-Bastien. I've been an optometrist for about 13 years. First few years in practice, I did many modes of practice. I was a clinician at the Université de Montréal. And in 2015, when I bought the practice, I really wanted to use technologies to improve patient outcome, patient comfort. And that's where year over year, I improved the practice. And in 2019, joined the IM Eye Care group. And since then, we've been continually improving our mode of practice. We're now pretty much ready to go. If you have any questions, Stephanie is on the call. You can write questions on the chat function of Zoom, and she can answer right away. If there's some questions she can't answer right away, we'll take 5 minutes to go over those at the end. All in all, it'll be about 20 minutes going over different treatment options and what dry eyes are. So let's go with it. First off, I want you guys to think of your eyes, your cornea is a bit like a windshield, okay? So every time you go for a blink, compare that to a wiper. You're going through a day, you're blinking 15,000 times per day. And if the surface of the eye is not well lubricated, every time you blink, it's going to damage the ocular surface, hence causing irritation, but also it'll make the vision blurry, much like a cracked windshield. You won't be able to see well through that cornea. So how common, how frequent do we see dry eyes in practice? Quite frequent, but in general population, we're talking about 20% of the general population. And a lot of people think, oh, what, dry eyes is an old folk disease. This study was done in Ontario, actually, just a couple years ago. And you can see it affects all age groups, not only 65 plus. You see, 18 to 39, yes, a little less so, but it's still very prevalent. People are on their cell phones all day, they're using digital screens. So we're seeing young patients with pretty severe dry eyes. So it's not true to say that it's only old folks that have dry eyes. So to better understand the treatment options that we have, it's important to understand what the tear film is, different compositions, and what's the function. So much like the windshield we had before, one of the main function is to lubricate the eye. So like I was saying, 15,000 blinks a day will irritate the eye if there's not something to lubricate it. The tears also moisturize the cornea. So if it wasn't for those tears, the cornea would be, desiccated and cracking. The tears bring, much like the blood brings to your different organs, the tears actually carry nutrients and oxygen for the cornea to function properly. And it plays a big role. The mucous tissue of the eye is the one mucous tissue in the body that's most exposed to irritants to the environment. So, elements like dirt, dust, and bacteria are constantly trying to aggress the cornea. So if it wasn't for that tear layer, the cornea would get infected pretty fast. Last but not least, the tear layer needs to be nice and smooth in order to have clear vision. A lot of people come in with very little symptoms of grayness and irritation, but they start reading, and after 15, 20 minutes, things go blurry. Well, that's because the tear layer is not nice and smooth. The first thing when the light goes into the eyeball, first thing goes through is the tear layer. And if that tear layer is breaking up, the tears will just dissipate, disperse in all directions, and you get blurry vision. So the tear film, although it looks like a simple thing, there's actually 2,000 different molecules that compose that tear film. And when the tear film starts to degrade, all those important proteins and nutrients that are nourishing the cornea degrade. And you see on the right-hand side, a dry eye will have much less in terms of quality of the nutrients getting to the cornea. So the tear layer is very, very important in keeping the eye from getting irritated. If you think of the thickness of the tear layer, you're thinking about just 1/10 of the thickness of a hair. So what are the sources of dry eyes? There's three different components really that make up the tear film. Okay, so the thickest of the three you see on the image here is the blue part, is the aqueous layer, and that's produced by the lacrimal gland. The lacrimal gland is it's contained just under the eyebrow, just here, and there's a basal production of the aqueous part. You have the mucus, the mucin layer, which is what makes the water component stick to the cornea. And you have the most important of the three, which is the lipid layer. The lipid is really what prevents the tears from evaporating. So when you look at percentage, only about 14% of patients lack truly just the aqueous part, but 86% of patients have a lipid deficiency. So essentially the tears are evaporating constantly, although there's enough water being created, there's just constant evaporation. And about 35% of those patients, it's a mix of, both aqueous and lipid layer deficiency. So in terms of basic phase 1 treatment, a lot of you probably, suffer of dry eyes, hence why you're listening to this webinar. This is really the classic 4 we give as a first phase treatment for very, very basic dry eyes. Essentially lubricating eye drops, omega-3 supplements, hot therapeutic mask, and lid hygiene. Okay, so they're all very important also, after performing in-house treatment, therapeutic treatments, and maintaining the situation. But this is very, very basic stuff, but it actually makes a big difference in controlling those symptoms. But it doesn't fix that root cause of, if we go back to the slide, the meibomian glands that we see that are contained in the lid margin, it doesn't get those oil glands working again, okay? It only alleviates the symptom. So talking about lid hygiene, probably many of you have been prescribed, lid scrubs or baby shampoo for the lid margin. We know full well that doing those treatments alone has a really small chance of getting really to the base of the lashes and getting really clean lids and really having a nice effect. Okay, lid hygiene alone has really limited effect. It's really important to have an in-house treatment to get really all that gunk off the base of the lashes. So when you do get home and try to clean the base of the lashes, at least you're starting off on an already clean lid. So we offer different treatment to clean the base of the lashes. Essentially, they're called Zest or BlephX microexfoliation. So the idea is to get all that Demodex, so get all those mites, get all the bacterial overgrowth off of the lashes, so the inflammation will be way down, and there's a chance for the lids to the tears to start being less hypertonic, less inflammation in them. It's a non-invasive, comfortable procedure, so it's done in a matter of like 10 minutes, but it feels really refreshing. Once you have the treatment done, most patients are like, oh my God, this is what really, my eyes should have felt like a long time ago. It feels really fresh, really comfortable. So again, I mentioned Demodex dust mites. So they're not dust mites, actually. They're mites that live in the base of the lashes in the same family as dust mites. Essentially, they feed off of the oil in the base of the lashes. And actually, when you're looking at prevalence, it's actually present, patients 60 plus, 2/3 of patients will have some Demodex. Not everyone needs treatment for it, in a sense where some people have just a little bit, not enough inflammation, but a lot of people have quite a bit, and it's really causing irritation to the lid margin. So the meibomian glands, like we were saying before, the meibomian glands are responsible for producing the oil that prevents the evaporation. Why are the meibomian glands dropping off? Well, the main reasons, digital screens, patients with rosacea, and patients wearing contact lenses really causes chronic inflammation that really clogs up the opening of the oil glands. If we look on the image in green on the top left, we see that whole row actually is pictures of the meibomian glands. And this is a test we perform on all and every patient that comes through here for a regular checkup. Whether they have dry eyes or not, we want to see these oil glands. So if there's atrophy, we can treat early and not wait for the oil glands to be completely decimated. So on the top left is a normal looking lid. And as you go from left to right, you can see the oil glands getting more tortuous, more dilated. Eventually on the right, we see severe atrophy of the meibomian glands. The oil that's in there is probably quite insipitated, probably very, very stiff. If we look on the bottom image, we see, the top is the structure, the bottom is the function. How well do the oils function? The oil glands function. When we press during the eye exam, we don't use the tweezers during the general checkup, but we do press on every patient's lid to see what's the quality of the oil all patients produce. And essentially it ranges, I like to compare it to oil, yogurt, butter. So as we go through, as the years go by, the oil glands stiffen up, and the more severe the atrophy, usually the more severe the blockage and the congestion in the oil glands. So I'll just show you, this is an expression following an IPL treatment, just so you can appreciate what the oil glands can actually look like sometimes. So although this lid is not very inflamed, it shows quite the thickness. It's very thick. This is very, very advanced blockage. So each patient, we express the oil glands, not with these tweezers, but we have a meibomian gland expressor and really qualify how good the quality of the oil is, and it decide the treatment plan better. And the next video I'll show you is the tear breakup time. This is another clinical point we look at, is how long does it take between each blink for the tears to break up. So typically once you blink, the tears are supposed to be stable for 10-12 seconds. So between each blink, the tears are not supposed to break up. In this case, within a couple seconds, you see where the black, where it's green is normal. When it goes a little dark, a little black, it breaks up. And that's really a very, very short breakup time. So this patient will experience that feeling of dryness, irritation pretty fast. And it's going to blur the vision. Like the vision might be clear for a split second. And then as soon as that tear layer goes like that, the vision blurs. So how do we treat these meibomian glands? So there's treatments that have been around for quite a few years, actually. Patients come to us like, oh my God, these are new treatments. Why was I never told about this? Actually, LipiFlow is the gold standard to treat meibomian gland dysfunction. It came out as FDA approved in 2011. And the goal, if you look at the contraption on the left, the white part actually heats the inside of the lid, and the outside massages and expresses that pressure, expresses the meibomian glands. It's a 12-minute procedure. It's not painful. We put an anesthetic drop on the eyeball. We put the activator on, and it does, people feel like they're in a spa treatment. And the treatment is actually very, very efficient. All the treatments we're going to go over are all clinically proven, evidence-based studies that show that these treatments work. And this, in particular, LipiFlow is proven to have an 85% improvement in symptoms after doing the treatment. So the main goal here is not to treat the inflammation, but really to decongest the oil glands, get that hardened oil out of the meibomian glands and get them flowing again. Another instrument we use to unclog the meibomian glands is the iLux treatment by Alcon. So this instrument is a handheld device, and we essentially, same thing, we heat the inside of the lid, we massage the outside. What's particular about this one is we can actually personalize the treatment. We can treat the zones we want for as long as we want. So that's the main advantage with the iLux treatment. So next treatment we do for dry eyes. A lot of patients show a lot of inflammation, irritation to the lid margin, rosacea. So that's where we use the IPL. IPL is for intense pulse light. It was FDA approved something like 1995. So it's been around. It's been used in dermatoaesthetics for decades. So it's very proven technology, and it was approved to be used for dry eyes in Canada in 2019. And so applying it to the lid margin, it actually makes the small blood vessels, it cauterizes the small blood vessels and dissipates them. So it really reduces that inflammatory load to the lid margin. And the nice thing about it also, it strengthens the collagen fibers around the eyes. So there's a nice aesthetic effect to it also. So like I was saying, IPL we use mostly patients that have inflammation to the lid margin. Rosacea is very, very common disease. And, in Caucasians, we're talking about 15% of Caucasians in general that have rosacea. And of that 15%, about 80% will have some ocular manifestation. And what happens in rosacea is that the small, there's a bunch of little small blood vessels that dilate on the skin surface, and they bring a lot of inflammatory mediators like interleukins, and it just causes chronic inflammation. And over time, if you leave that inflammation there, if you leave the lid margin inflamed, it'll lead to hyperkeratinization, and it's going to change that that structure of the lid margin. So the idea is to really reduce the inflammation to the lid margin to give a chance for the oil glands to start functioning again. Another way to address to get the oil glands, to stimulate the oil glands, is through low level laser light therapy, LLT, or photobiomodulation. So a little different than the IPL. IPL is really like when we treat the patient, much like a strobe light effect on the eye. This is more a steady, there's two masks actually. There's a red mask and a blue mask. It's a half mask actually. And so when you put it on the eye, what it does, the red mask will actually stimulate the body to produce more energy. So it's not the mask that's so hot, it's the light stimulates the body to produce more heat, and that heat stimulates the meibomian glands, and it stimulates the mitochondria to produce that extra energy, and it's stimulated for weeks after the treatment. So it helps the body restore and regenerate. The other mask we use is the blue mask. The blue mask acts more on a superficial level. So it'll kill off the bacteria on the surface of the lashes, kill off those mites, the Demodex we were talking about just before. So we use the LLT, most patients with dry eyes, patients with chronic blepharitis, with styes, patients with chalazions, we use the mask with quite a bit of success. Another treatment that's available, and it's another one that's been derived from dermatoaesthetics, is radiofrequency. So with radiofrequency, we apply it looks like a pen almost, and we go along the lids, the top and the bottom lid, and what it does, it stimulates the meibomian glands through a magnetic field. And it heats the meibomian gland. It stimulates collagen synthesis also. So it has a nice aesthetic effect, but also it stimulates the oil gland. So it's sort of used not only for aesthetics, but really to stimulate those oil glands to produce better. So all the different technologies we talked about, the IPL, LLT, LipiFlow, they're all technologies to get the oil glands to work better. What about the patients that don't produce enough of the aqueous portion? Okay, so patients that don't produce enough of the aqueous portion, well, the risk factors, the main causes for not producing enough of the aqueous is different autoimmune disease like Sjogren's. A lot of patients come in with Sjogren's or rheumatoid arthritis, lupus. So they're all diseases that will reduce the basal production of the aqueous part. Different medications, antihistamine, antidepressants, diuretics, they're all medication that will reduce your basal production of the aqueous portion of the tears. Different surgeries like LASIK, especially the first few months or first few years, a lot of patients will have reduced production. And some people actually with LASIK, it can be 10, 15, 20 years, can stay quite a long time after. And also with age, like we said before, with the age groups, as you grow older, you do start producing a little less of the aqueous part. So what are the treatment options for the aqueous deficiency patients? So one way to cool down, get the patients getting comfortable quite fast is using cortisone drops. Very famous drop here, Lotemax gel, gets the eyes comfortable quite fast. The only thing, we can't use cortisone long term. It can cause the raise in pressure, it can cause cataracts. So very good at making the patient feel better, but it doesn't change anything on the long run. Okay, so that's why some drops came out many years ago, drops like Restasis, Xiidra, and last year's Sequay. So they're all drops that are immunosuppressants, so they'll act much like a cortisone drop, but without the side effects. It reduces the inflammatory component of dry eyes. The only downside is use it twice a day. Long term, is when you stop using it, usually the effect is lost pretty fast. But it is a very, very good option for patients with chronic dry eyes from aqueous deficiency. The IPL will also help stimulate not only the oil glands produce more, but it does stimulate the nervous system to produce more tears. So IPL can be used with aqueous deficient patients also. If you look on the bottom left picture, you see a scleral lens. Scleral lens is a very large contact lens you put on the eyeball, and you fill that lens with a saline solution. So essentially the lid, the cornea is actually sitting in a bath of aqueous solution all day. So for a patient not producing enough tear, this is a very good solution for comfort. On the top image, you see, so when you produce tears, when we're saying the eyes protected, protecting from the environment, it's flushing out debris. While the tears flush out through, there's two punctum on the top and the bottom, and that's where the fluid flows out of the eye through the nose. And you can use punctal plugs to prevent the tears from flushing down the nose. So if you're not producing enough aqueous, well, why not just put a plug and keep the aqueous on the surface? So very good solution. And one new solution also that's been that we've added is protein-rich plasma drops. So what is protein-rich plasma? It doesn't replace lubricating eye drop. It's a treatment that's developed from essentially you draw the particular patient that wants to have protein-rich plasma treatment is drawn blood, and then from that blood it's centrifuged, and the protein-rich plasma is extracted and sent in a bunch of little vials that you can use for a few weeks or 2 to 4 weeks in the eyes. And so the advantage with this is that it's full of a bunch of proteins that are anti-inflammatory, anti-scarring. It's much better than a lubricating drop at helping the surface of the eye regenerate. It's preservative free, and it like I said, it doesn't replace a long-term lubricating drop, but it's a treatment really to get the body to take control of that chronic inflammation. So again, protein-rich plasma, blood drawn from it's not someone else's blood, it's your own blood drawn, and the tears are created from that centrifuged blood that's drawn. Next, we'll talk about a bit about cataract and LASIK surgery. In my opinion, all patients should be screened for dry eyes before they're even sent for cataract surgery or LASIK pre-op measurements, because one of the main thing when you take measurements to do these types of surgeries, you need to have a nice smooth ocular surface. If you have bad measurements coming in, you'll have terrible outcome. You'll have terrible results coming out. So if you look at the image on the top right, that multicolored topography there, we see red spots, green spots. So that's a very irregular cornea. If I'm that patient going in and I take that for readings to choose my intraocular implant after cataract surgery, well, the treatment options will be terrible. The outcome is going to be terrible because the readings are off. So if you look, that's the same patient on the top and the bottom. You see how smooth the cornea has been after treating the dry eyes. If you do surgery measurements and you choose an IOL, intraocular lens after taking the bottom image, you'll have you'll have more options and you'll have much better result. So if we look the FACO study here, actually, so this is a study that was that looked at all patients going in for cataract surgery, and it was looking at how many patients were diagnosed before and how many patients were diagnosed at the time of the workup for the cataract surgery. And so 81% of patients were diagnosed with moderate to severe dry eyes, whereas only 22% knew about it before they went in. So very, very underdiagnosed. And I think every patient going in for cataract surgery should consult to have a dry eye evaluation, or at least use drops heavily before going in for those measurements. So as I was saying before, if you have a healthy ocular surface, there'll be better measurements. And with better measurements, you can have more options. I mean, you can do lenses, the implants for cataract surgery. You can have a toric lens, you can have a multifocal lens, you have a multifocal toric lens. So they're specialty lenses, but they won't be available to you if your cornea is all mangled. So very important to treat those dry eyes before even going in for cataract evaluation. Another factor that can cause dry eyes is the use of drops for glaucoma. Close to 100% of patients using anti-glaucoma drops for more than 2 years suffer from dry eyes. So essentially, the chronic use of those medication with the preservatives in them just causes dry eyes. So there's different options to treat the dry eyes, but there's also some drops now are coming out without the preservatives, so a little softer on the eyes. So essentially, we went over all the treatment options in terms of in-house treatments, at-home treatment. What's really nice, to be an optometrist treating dry eyes in 2023 is there's a lot more options. When I first graduated 13 years ago, it was like, here's some drops, here's a hot mask, and let's pray for the best. Now we can really look at each patient, see how much inflammation there is, how much obstruction there is to the meibomian glands, quantify what's, how much they're producing in terms of aqueous, and then we can really tailor what the best treatment plan will be with different, treatments that will assess that exact presentation. So yeah, what's important really is to understand that these treatments are all clinically proven to work, and what we're treating is the root cause. So we're not just patching the symptom, we're really fixing the root cause of the issue, which is, like we said, 86% of patients have meibomian gland dysfunction. So yeah, most of you, questioning why are my eyes so dry? Odds are we can improve the symptoms through using the technologies we have here at IM. I hope you guys enjoyed the talk, or my talk. I mean, I didn't hear you guys much. It's my first ever webinar. We'll probably be doing more of them, but I hope you guys enjoyed. I'm going to check real quick with Stephanie if we had any questions. No questions. Okay, I guess I was pretty clear. If you have any, raised hand. Thanks for joining us. We have Olivier on the line.
First question is, where do you practice?
Essentially, we have 4 different locations. Okay,
That
firstly,
I know.
I practice in Dorval.
Okay.
Dorval, right before the circle. It's 990 Chemin Errant. There's 3 other locations. So there's one in Angus, in Montreal, close to the stadium. One in another location in Boucherville, and one in Quebec City, the original IM.
Are you guys all connected, like computer wise and all that? So if one client goes from one city to the next, he can get treatment follow up easily?
Yeah, well, we're all based on the same platform. Each clinic, we can share files, but it's not exactly the same program. But yes, like if you say, I wanted to have a treatment started in Quebec City and follow up in Dorval, we can work. Yeah, we can talk to each other from one to the other. Yeah.
So I see there's many types of treatments. However, I'm trying to figure out for my issue or anyone that has one issue or another, which treatment is best, or should you have a combination of treatments?
So, as the years go by, we start all these treatments. The IPL we started right around COVID. LipiFlow, we've been doing for years. And as the years go by, really what's proven to work best is to have one treatment to really decongest the oil glands. Okay, so if you remember, we talked about LipiFlow and Ilux. So those are really like thermomechanic treatments to really free up the oil glands, and then to have one treatment to reduce the inflammation. So that's why we tailor the treatment. Someone doesn't show, lid margin inflammation, no rosacea, the IPL is not necessary, but the best treatment, most patients will show rosacea with meibomian gland dysfunction. So that would be IPL and LipiFlow combined together.
So let's say somebody does those 2 treatments. What would be the time frame that they'd have to do it on?
So the IPL, very good question. So the IPL, we spread the treatments over. It's a series of 4 treatments. Doing one IPL just alone won't do much. It'll help a bit, but not enough. So we do 4 sessions spread by 3 weeks. So all in all, from first to 4th treatment, you're talking about 3 months time.
So there's the other treatment after the IPL, which is the
LipiFlow we do during the 3rd visit, actually. So we wait for the IPL to start kicking in and having its nice effect at reducing the inflammation. And then the LipiFlow we do on the 3rd session usually. That's what most optometrists in our group like to do.
So halfway through,
yeah,
and you switch, and then you go back to the first one, right?
Yeah, well, we do 4 sessions of the IPL, and on the 3rd session we do combined treatment of IPL and LipiFlow. So we do both.
LipiFlow is only one treatment, or am I confused?
It's a one treatment, lasts about 15 minutes all in all.
Let's say that the person completes that, and how long is it before they can see an improvement, and how long would you say it would last?
So dry eyes is, like we said, dry eyes is a chronic situation. So we've had patients do the treatment, feel like $1 million for a year, 6 months, 12 months, year and a half. and they come back and they sort of slowly crept back. So typically we like to follow patients every 6 months when they do the IPL and everything's under control. We'll see the patient after 6 months and we'll do one single session of the IPL to maintain, and then we reassess what at-home treatments are needed. But typically the IPL the symptoms will be better after the third session. Okay. Usually they feel the improvement, starting second to third session, and the lasting effect. Some people, I would say, it's hard for me to say, but I'd say, if you go over 12 months without treatment, odds are the symptoms might start to come back. But, it all depends on the patient and the situation. But I like to treat patients every 6 months to make sure the treatments don't start kicking back in, and we don't have to start treating, from
square one,
cause de départ,
Right. So which treatment is the follow-up treatment? Is it the IPL or is it the
single set? Well, yeah. Well, I look at the ocular surface. I try to see what would be most beneficial, but most of the time it's an IPL treatment. That's the follow-up. If we initiate it with 4 IPLs, then that's what we do at the follow-up. We discuss between the patient that, we see what the symptoms are. We use a questionnaire to know exactly how the patient feels before and after, so we can follow up with the patient really and understand how much better the symptoms are getting. So everyone's a bit different in timeline and different follow-ups. It's no situation is exactly the same.
Makes sense. And no, I think it's, I really appreciate your frankness, and I find it much more clear for me now. And at least, it gives me a good area of time frame to plan.
We have another question coming in. You can always,
well, thank you very much.
It's my pleasure. You can always type in your questions if anyone has any other further questions. I'll allow Mr. Patrick to talk now.
Can you hear me?
Oh, there you go.
Okay. Is RAMQ involved in some public support for these strategies and program?
I mean, RAMQ is still covering the same eye exam as 1984. And unfortunately, they haven't added any, like for optometrists, it's the same billing code, same everything. They added new rights to prescribe for glaucoma and all that, but they've never added anything. So unfortunately, the only thing they'll cover if the patient has really severe dry eyes, they'll cover drops, the immunosuppressing drops. You have to prove that the patient has severe dry eyes using thick lubricating drops, and it's really affecting the patient's lifestyle. And then they'll cover the drops, but they don't cover any of the treatments, unfortunately. If it was, then a lot of more optometrists, I think, would be offering these treatments. Yeah,
that's quite disappointing for sure, and that's not sharing the benefit of these strategies. Also, is there a significant difference between drops that are preservative free and drops that are not so?
Yeah, many studies show. I'd have to look them up for you, but there's many studies that show, if you're putting drops in every day, the preservatives will cause irritation to the eyes. So definitely go with preservative free drops. For someone who's got mild dry eyes, using drops here and there, it could do the job. But when we look at the main study that gave us the outlines for this, the TFOS-DUES 2, and when you get to phase 2 treatment, the preservative free drops is like number 1 on there. So definitely stick to preservative free.
I've had some success with heat compresses. And do you recommend that?
Yeah, well, the hot mask will actually help, express a bit of the oil. Like if you look at the total length of the oil gland, maybe that first 5 or 10% of the oil gland will be softened up, but you got to remember in the lid, there's a pretty thick muscle there that absorbs all of the heat. So the only heat that's going through is through the opening. So it's only you're only expressing very small portion of the meibomian gland. So any atrophy that's ongoing, like we saw in the slides where the oil gland was getting shorter and shorter and shorter, it's only expressing the opening and not the top part where the atrophy is happening.
Is it a good idea to open your lids somewhat to get the benefit while the compress is on you?
No, because whether if the eyes are open or closed, it's still not going through the it's not going through the top skin part. It's only going through like the opening. So no, I wouldn't do that because you'd risk probably scratching the corner.
Yeah.
So.
Well, thank you.
Yeah, that's the whole reason the LipiFlow has been designed, is to provide heat from the underside of the lid and really soften up the entirety of the meibomian gland. Our iDrop Pure drops superior to HydroSense drops. iDrop Pure, yes, in terms of stability. I mean, HydroSense has. We have a question from an anonymous attendee. HydroSense drops. Well, there's different HydroSense drops on the market. iDrop, iPure drops there's different ones out there. My go-to drop for severe dry eyes, there's in the iDrop Pure gel really has a nice thick, long lasting. It lasts about 4 hours. The only downside, it's a good one, but the iDrop Pure gel has much longer lasting effect. I mean, it'll stay stable on the eyeball for quite a long time, but it depends which one you're comparing to. It's a very big question. Was there any other question? Stephanie is signaling there are no more questions. So we'll I think this will be a wrap. I hope you guys enjoyed. And this is my first webinar, hopefully not my last. Next one will probably be even better. So I'll be happy to see you guys all again. Thank you.